Hi everyone, welcome back to our interactive nclex-rn review session. And now we are on day 30th for the 90-day review series that we're offering free. Now we really want you to enroll into our dynamic NCLEX review course at Stancoast NCLEX Coaching for personalized support. We want to make sure that you can access to our 3,000 plus NCLEX style questions and also 10 hours of animated videos for your flexible study. And we want to make sure that you will be able to gain that confidence with our on-demand video library and also practice exams, and make sure that you can also engage with us at our website. Now, for more information, we are encouraging you to visit at our website. We have at www.stancoast-nclexcoaching.com. And we do appreciate all your comments and feedbacks and all the questions, and we are happy to help you with those. So kindly do that. If you could put all the comments or in the chat box or in the comment section below, please do so. Now, today we'll be getting into the different NCLEX questions, and this will all be about myocardial infarction. So this will be day 1 of 2. And we will be doing the questions right away, and then we'll touch base with those different sections of MI. Now, we'll have the first question right now. I want to make sure that you're paying attention, and if you could put in your answers in the comment section or the chat box so we can follow through who's really participating. And so we have our first question right here. It says, when caring for a client with cardiac issues, or when caring for a client with cardiac issues, the nurse understands that the primary condition responsible for causing myocardial infarction is which of the following? Is it A, aneurysm, B, heart failure, C, thrombosis in the coronary artery, or D, renal disease? You have your options right there. A, aneurysm, B, heart failure, C, thrombosis in the coronary artery, D, renal disease. So take your pick. All right, let's get started with the different options here. So if you're selecting letter A, aneurysm, would that be correct? Well, the aneurysm basically is going to involve an abnormal bulging or ballooning of the blood vessel wall. And this is typically going to occur in an artery, okay? While the aneurysms can lead to the complications, maybe a rupture or maybe thrombosis, they do not directly cause the MI. And so, again, this is not going to be our answer this time. We're going to eliminate aneurysm. Okay. So, by the way, I hope that you were able to capture really the question here. We are looking for that condition that can cause the lack of supply or blood supply or oxygen into the muscle. Okay. So we are looking for that cause. And most of the time, again, this is going to be an insufficiency and subsequently an immediate stop in the blood supply to that muscle, heart muscle. Okay, so I'm seeing answers here, letter B and C. Now, let's take a look into letter B, heart failure. How is that significant? Is it? Well, the heart failure basically is going to result from an MI. So it's the exact opposite. Heart failure doesn't really lead to MI, but it's the other way around. Myocardial infarction can lead to or will complicate into heart failure. Okay, so the heart failure is the weakening of the heart muscle. And again, this is a complication of MI, not the other way around. Okay, so we are not selecting this option either. Now let's take a look at letter C. Is this going to be a correct answer? I believe so. Well, thrombosis in the coronary artery, it's basically that lodging. It's the formation of the blood clot within the coronary artery. And this could possibly happen as when the clot gets trapped into that narrowed blood vessels where the atherosclerosis is. And so with that, it will grow over time and eventually it will really block that blood flow. And this will now cause the impairment of blood supply to the tissue, and eventually it will cause ischemia and eventually infarction and necrosis. All right. So there's that ischemia, first thing. A lack of blood supply to the muscle tissue, and then followed by infarction and also necrosis. The muscle or the cells there are no longer going to be able to function after there is that necrosis. It's that cellular death. And so when that happens, it can possibly lead into the congestive heart failure because the muscle is no longer viable. It will not be able to do its job in pumping the blood from the ventricle into the systemic circulation if we are talking about the left side. And then, yeah, again, going back into that complication leading to heart failure. Now let's take a look at letter D. Why is letter D not really the cause for myocardial infarction? Well, this is something that is actually the renal disease will be one of those subsequent or complications when there is myocardial infarction and possibly leading to cardiogenic shock. And also if there is, in a case of maybe hypertension and diabetes, and so there is now impairment of blood supply to the kidneys, could probably be a pre-renal cause. There is poor oxygenation to the renal tissue, and so this can lead into that acute renal failure or acute kidney disease. But again, the renal disease is not going to be a direct cause of the MI. Okay, now let's get reviewing here. So we are going to select our answer here, which is thrombosis of the coronary artery. That would be our selection, letter C. Now, again, let's go back into the concept of the pathological changes in myocardial infarction. Again, it starts with the coronary artery blockage. Let's simplify this. So the progression of the disease starts with that coronary artery blockage, and this is going to form that clot. It will grow bigger where there is a buildup of that plaque or the atherosclerosis. So it will partially or completely block the blood flow, and it will now cause lack of O2 into the distal muscle or distal cell. There is poor perfusion. And then when that happens, well, of course, if there is now complete blockage, then this is going to lead into that cell damage and death, ischemia and infarction. So we'll just simplify this. And then when there's that cell damage occurring, this can also lead into some inflammatory responses. It can also worsen the damage and could lead into scar tissue formation. So this is going to be followed by the inflammatory response. And this is going to be a lot scarier this time. When there is rapidly evolving myocardial infarction, And this is the critical time, guys, when you are going to be taking care of a patient with an MI. During the first 24 hours or 48 hours, this is the time that you really need to keep an eye on this patient, because this is the time that they can develop into the life-threatening dysrhythmias. Okay, so the MI itself, because of the cell tissue, the myocardial infarction, necrosis, it can lead into those abnormal heart rhythms. And these are your ventricular tachycardia. So let me just shorten that as a ventricular tach, and also the ventricular fibrillation, VFib. Let me just shorten that one, VFib, and ventricular tachycardia. So these are both life-threatening, but of course, ventricular fib is the worst, right? And so we are going to make sure that our patient around this time is closely monitored. Of course, we have to keep an eye onto their continuous cardiac monitoring to capture those life-threatening or deadly heart rhythms. And so we definitely need to make sure that our patient is being treated if there is probably a need for us to do anticoagulation during the acute phase. We definitely need to do that, or could be with the treatment using the fibrinolytic agent, the TPA, in order to bust or to dissolve the clot. Hello, everyone for those who just joined in, welcome back to our session today. We are talking about myocardial infarction, and we just started answering the first question. And so, our answer for this test item is letter C. I was ready to put letter A, but our answer is letter C. Thrombosis in the coronary artery. Okay, so I hope this is simplifying your understanding about the myocardial infarction, and we'll try our best to make it more understandable and easy to digest. All right. Now, again, our strategy here in answering this question is we want to make sure that you recall the pathophysiology and also the sequence of the events, right? Why is there an ischemia? Why is there an infarction? Okay, well, it starts with that coronary blockage, thrombosis. Could be a partial into a complete obstruction and subsequently causing myocardial death. Okay, and we want to make sure that you are doing the elimination process. When you are going through the choices, I really recommend you go through the options. Do not look for the answers. So what are you going to do here is to rule out those options that are consequences of the MI, okay, like heart failure. So this is something that can help you in eliminating those other options, because heart failure cannot lead into MI. It's the exact opposite, okay? Or for the renal disease, which is pretty much an unrelated causative event, it doesn't, all right? So it will narrow down your options. So probably, hey, I got two more remaining good options. So that way, that by the time that you're almost done and really comprehending the test question and the option, then yeah, you are now limited to getting that almost correct answer up until you finally decide that, hey, I'm actually gonna get this option, letter C. Okay, so make sure that you do that, guys. Always recall about the pathophysiology. You don't really need to be very good in tracing the arrows or whatever, but at least you have that basic information about what is really going to lead to the MI. Okay, now let's go into the next question here. Question number 2. Following an anterior wall MI, what condition is suggested by hearing crackles in the lungs during auscultation? Again, following an anterior wall MI, what condition is suggested by hearing crackles in the lungs during auscultation? Is it because of A, left-sided heart failure? Or is it B, pulmonic valve dysfunction? Or is it C, right-sided heart failure? And lastly, the tricuspid valve dysfunction. What do you think about this question? Again, our option here, left-sided heart failure, pulmonic valve dysfunction, right-sided heart failure, tricuspid valve dysfunction. Okay, very good. Hello, everyone. For those who just came in to join us, welcome back. Yeah, I'm seeing a lot of A's right now. That's a good sign. Okay. All right. So, again, the question said, following an anterior wall MI, what condition is suggested by hearing crackles in the lungs during auscultation? When you're going to get to that point, when you are hearing those crackles, yeah, the patient has already developed that complication. And we just want you to identify what complication has set into this patient. Yeah. And guys, take a look into the exact site, anterior wall MI. This is going to be your clue, because this will lead you into selecting that complication. So you have to remember the positions, the anatomical position of those chambers and corresponding organs. So let's take a look in letter A, left-sided heart failure. Is that correct? Yes, that is a correct answer. Let me write that down here. Correct answer. Letter A. Because the anterior MI, anterior wall MI, it will actually impair the function of the left ventricle. Left ventricle, which is basically that chamber that is going to be responsible in pumping the blood from the left ventricle, right, into the body, the systemic circulation. And so let's take a look here. Yeah, so here we go. When we have an anterior wall MI, basically the affected coronary artery is basically going to be mostly in the left anterior descending artery, okay? So basically this is going to affect this section of the heart, which is basically on the left chamber, especially the left ventricle. And remember, guys, that the left ventricle is the hardest, the hardest worker of all the four chambers, because it has to overcome the peripheral vascular resistance, right? Again, our hardest worker is the left ventricle. And that's the reason for that. It's because it has to overcome the systemic vascular resistance. What is that systemic vascular resistance? This is the amount of pressure that the left ventricle has to overcome when it's pumping the blood from the left ventricle, right? So take a look here. Basically, this is the artery, right? The aorta, which is the biggest, one of the biggest artery, the biggest artery in the body. And so the left ventricle supposedly, let me just erase this so not to confuse you guys. So when the ventricle pumps in the normally functioning body, the left ventricle will work harder to pump the blood out into the body, wanting to expel that blood into the aorta in order that it can be distributed into the systemic circulation. But take note, guys, that the blood vessels will become smaller, they will become narrower after they get passed through the aorta, okay? So please take note of that. Again, there is that systemic vascular resistance because the size of the lumen, especially the arteries in the systemic circulations, are smaller, okay, after the blood passes through the aorta. And that the small size of the lumen, or the smaller the artery is, then the higher the pressure is going to be. And so this is what's making the left ventricle as the hardest worker in order for it to pump effectively the blood. Okay, so I hope that you're getting that concept. Now, in the case of this patient that has a thrombosis into the left anterior descending artery, if there's that clot over here lodging into this, of course, this is going to affect the oxygenation. It will impair the oxygenation until it can get ischemic, infarcted, and necrotic, right? So it will no longer be able to pump the blood effectively, right? So this will now become weakened, no longer able to pump. Probably there's a little bit percentage that can get pumped into the systemic circulation, but it's no longer effective. So what's going to happen? It will now cause backflow of the blood into the left atrium and eventually into the pulmonary veins, and it will go back into the pulmonary capillaries, where it can lead into shifting fluids from the pulmonary capillaries. It will now shift into the alveoli. That's why you're going to hear those crackles. And again, that's because of the increasing hydrostatic pressure in the pulmonary circulation. Hydrostatic pressure. Because of that backflow. Right? So, as we are talking about letter A, this is our answer because, again, this is caused by that fluid or blood congestion accumulation in the alveoli, in the interstitial spaces as well, or the pulmonary capillaries. And again, when you are auscultating the patient, you will be hearing the crackles, like what we have in our scenario, hearing crackles. And aside from the crackles, of course, the oxygen saturation will also go down, right? Because it can impair the exchange of gases in the alveoli because of that abnormal accumulation of fluid, right? The air, the O2, will not be able to diffuse properly into the lining and into the capillary because of that fluid present in the alveoli, okay? And so the oxygen saturation will go down. Your patient is going to have some difficulty breathing, SOB, and also increasing respiratory rate. All right? Okay, dokie. Now let's move on to the next option here, pulmonic valve dysfunction. Why is this wrong? Well, when we are talking about the pulmonary valve or the pulmonic valve, this is basically that blood vessel, which is actually hidden right here. Instead of having this picture, let me just back up here so I can draw. Let me just erase this. Okay. With the pulmonary artery, let me create my own avocado heart. This is the right atrium, right ventricle, left atrium, left ventricle. So we are referring into letter B, pulmonic valve dysfunction. So basically that pulmonary artery is that great blood vessel rather. It's that big blood vessel that receives blood coming from the right ventricle. And it has that semilunar valve that will prevent the backflow, or it will allow the inflow of blood coming from the right ventricle into the pulmonary circulation. It will branch off into the right side or into the left side. And eventually it will pass the blood into the pulmonary capillaries, right? So let me just highlight this one right here as our pulmonary artery branching off to the right and branching off to the left. Okay. Again, there is that valve, the pulmonic valve, that is found here in order to prevent the backflow in a normally functioning person, right? If we are answering letter B, pulmonic valve dysfunction, then it can lead into, if there is a problem in the pulmonary valve, it can lead into pulmonary hypertension, but it does not typically cause crackles, okay? All right, so again, if there is pulmonary valve dysfunction, let me erase this. Again, I said that it will cause pulmonary hypertension. So we're talking about the pulmonary hypertension. We're talking about the main right and left branches of the pulmonary artery. There will be a high pressure in that area. Okay. When this happens, it can lead into the backflow of the blood into the right ventricle. So the target spot will be the right ventricle. It will not be the left ventricle. Okay. So with this pulmonary hypertension over time, it can also lead to the weakening of the left, or the right side rather, the right ventricle. So it can also lead to that, what we call as right-sided heart failure. Okay, I really want you to recall in that discussion that I made regarding pulmonary hypertension. Yes, it's going to complicate into the right-sided heart failure. So the manifestations here are very different compared to the left-sided heart failure. Because again, if the right side of the heart is the problematic part of the body, there is that congestion into the right side of the heart. Again, congesting into the right atrium, it will also congest the largest, or this is the big vein right here, the vena cava. Okay, remember, it will now congest the vena cava, and the manifestations there will be mostly the edema. It could be the jugular venous distension, or it could lead into the portal hypertension, which will affect the liver as well. It can lead to the enlargement of the liver and also the nearby organs in the stomach, or in the abdomen rather, and also it can lead into the peripheral edema. So most of the time you're going to be seeing a lot of the weight gain. Let me just write it down here. Weight gain because of the edema. And then positive JVD, which is the jugular venous distension. The extrajugular vein will be very visible even if the patient is sitting upright. And in the normal person, you should not be seeing the extrajugular vein bulging. Okay, so that simply means that our patient has fluid volume excess in the venous circulation, okay, in the vena cava. All right, so that's about letter B, and it is incorrect. Now let's take a look on the right-sided heart failure. Well, it is closely associated to the letter B. So I'm not going to further explain because this is already my explanation about the B. So they're quite associated to each other. So we're going to skip that. What about the letter D? Tricuspid valve dysfunction. What is that? Remember about where the exact side of that tricuspid? Let me erase this. Let's go back to that. Ooh, it's not that correct. Not that picture. So the tricuspid valve, where can you find the tricuspid valve? Creating another avocado heart. The tricuspid valve is an atrioventricular valve that is found in between the right atrium and the right ventricle. Okay, so this is where the tricuspid valve is. Tricuspid valve. So it is that valve that will also control the passage of the blood coming from the right atrium down towards the right ventricle. And if there is a dysfunction in the tricuspid valve, it can cause a problem in the blood flow, of course, in these chambers, right? But it doesn't really cause a problem into the lungs. It doesn't lead to the presence of the crackles because, again, it's affecting the right side of the heart. So our focus here will be the backflowing as well, the vena cava, and if there is that congestion, again, it will be similar to the right-sided heart failure manifestations. Okay, so our correct answer here is letter A. Now, guys, our test taking strategy here is to make sure you are going to utilize what you have learned, your basic knowledge about the anatomy and also the physiology. Make sure that you are able to recall the anatomic compositions of those valves, the chamber, the function of the left ventricle, the function of the right ventricle, so you can pinpoint exactly what that complication is going to be. Okay, so again, let me simplify this. If we are talking about the left ventricle problem, well, let me just put LV impairment, or probably I'll just say left-sided heart failure, you should be expecting more of pulmonary manifestations because the lungs are the closest organs to the left ventricle. I mean, as looking into or thinking about the blood and the potential backflowing. And so that is why most of the manifestations that we're going to see in a patient with left-sided heart failure will be pulmonary signs and symptoms. Okay. However, if we are going to be worried about the right side or right-sided heart failure, or let's say the pulmonary artery, so our manifestations that we should be expecting are those systemic manifestations. I'm talking about edema, weight gain, okay? And we are talking about the right side of the heart here as a problem, right-sided heart failure. Edema, weight gain, JVD positive, and also the hepatomegaly. Okay, so just simplifying. All right, so let's move forward to the next question. Quite messy here. It looks like a war zone. Moving on to the next question. Question number 3. A client being assessed for myocardial infarction asks the nurse which test is commonly used to identify where heart damage has occurred. The best response is, okay, let me restate that. Question number 3. A client being assessed for myocardial infarction asks the nurse which test is commonly used to identify where heart muscle damage has occurred. The nurse's best response is A, cardiac catheterization, B, cardiac enzymes, C, echocardiogram, D, electrocardiogram. What is your answer? So our case here is still MI, and the patient is asking the nurse about what test will be commonly ordered or used to identify where the heart muscle damage has occurred. Okay, so it's asking for that specific specificity of that diagnostic test. Okay, I'm seeing letter C, I'm seeing letter A, Anita answered letter B. Okay, any more answers? I want to see more answers here, guys. Yeah, unfortunately, we are doing multiple choice most of the time. I mean, most of the test questions I have right now are multiple choice. Okay. Commonly used. Commonly used, that is a clue right there. And this is also pertaining to that preliminary diagnostic test that can pinpoint where the problem is. Okay, it's not going to be so expensive. Okay, so what do you think would that be? All right, so let's take a look in letter A. I'm seeing Bethany. Seeing Judith answering C, Bethany answered D. Okay. Cath lab is to identify blockage. Yes, I believe that. Yeah. But here, guys, we are testing you about the most commonly used, especially the primary commonly used diagnostic test. So just to answering letter D. So let's tackle letter A, cardiac catheterization. Well, the cardiac catheterization is a very good diagnostic tool, right? It is. It's very useful. It is invasive, of course. It is an invasive procedure. It requires consent, patient's consent. It may require sedation as well. Some other patients might be like half awake, half asleep. It will require injection of that conscious media and also to visualize those diseased part of the blood vessels in the coronary arteries. And it will also assess where the blockage is, okay? So it will check for the blockage, or blockages, where the clot has possibly lodged in. And it can also locate the myocardial damage, okay? Locates myocardial damage. But don't forget about the clue here, commonly used, okay? Now, what makes this option wrong is that it is not typically the first line testing to determine the location of the myocardial damage in the acute setting, okay? It is not. It will be done as a follow-up, okay? I have no doubt it is a very good diagnostic tool. Like I've said, it does a lot of things. It locates where the muscle damage is, also the blockages. It's invasive. However, it's done as a follow-up diagnostic tool, all right? And it's not the primary diagnostic test. That's why I'm not selecting this one. It's incorrect. What about letter B, cardiac enzymes? Those cardiac enzymes are going to be released into the circulation once there is cardiac damage or myocardial damage. So let me put here, released into the bloodstream after cardiac cell injury. All right. So it will now allow those enzymes to leak into the blood circulation. And that is why when the blood has been drawn, it will reveal that there will be elevation of those enzymes, CKMB, troponin I-T, myoglobin. But again, these cardiac enzymes will not help us in pinpointing exactly where the location has been, okay? So it does not pinpoint the damage, okay? It will not detect the damage. So that's why we are going to eliminate the cardiac enzymes. Now, what about letter C? Echocardiogram. So what is this testing? It's an ultrasound kind of testing, a more sophisticated kind of ultrasound that is going to assess the myocardial function. It can also check the heart's function, or let's say the movement or the motion of the blood or the blood flow inside the chambers of the heart. And it will also check for structural damage. It checks for structural damage. It can also detect complications, let's say movement, or maybe if there is a decrease in the ejection fraction, if the ventricle is no longer able to pump properly the blood, if there is weakening of that ventricle, then it can reveal a decrease in the ejection fraction, maybe less than 55%. So that is why the echocardiogram is also helpful in the diagnosis of MI. But again, this is not the primary diagnostic tool that will be ordered by the medical provider. Okay, so we are left with the letter D, EKG, the 12-lead EKG. All right, so this is the first and the primary diagnostic test that we can readily use when the patient has that MI. All right, so please take note of that electrocardiogram. And this is the most preferred method. It can quickly and it can accurately determine the location of the myocardial damage. Okay, so how will we know that it can do that? Well, of course, let me put here EKG, so you won't get confused with EKG, ECG. It's so synonymous. I don't know why they do that. And so, for example, if there is what we call as anterior wall MI, like what we have in the previous scenario. For example, if the patient has anterior wall MI, and again, this is going to be that end result whenever there is that occlusion into the left descending coronary artery, right? It can lead to that anterior wall MI. So what will the EKG reveal or the ECG reveal? It can reveal ST segment, or it can, the waveform will be ST segment elevation, or what we call STEMI, okay? ST segment elevation, or known as STEMI. And this is the most common MI that we will usually see in the majority of patients with acute MI, okay? There will be that ST segment elevation for anterior wall MI. However, though, there is that what we call as ST segment depression. Oh, before I go do that, let me clear this out here because it's getting busy. Yeah. Let me properly write that down because I can't even decipher my handwriting. So, anterior wall MI, ST segment elevation. Okay, and this is going to be seen in lead V4. Okay, so this is going to be in the anteroseptal type of leads. However, if you're going to see the ST depression, and we are still talking about the anterior wall MI, right? We have not migrated to another site yet. If this EKG will reveal ST depression, and this is going to be seen in leads 1, it also going to be in, no, lead 2 rather. Lead 2, lead 3, and lead AVF. And guys, we are not going to have to do the EKG, the full EKG right today, not yet, but I'm just going to show you where exactly that anterior wall is going to be, and also the corresponding EKG changes. All right. So again, the reason for that is because of the left anterior descending artery occlusion. Okay, that's on the anterior wall. Okay. Now, if we are talking about the posterior wall MI, okay, this is another one. Let me go to that picture right here because I want to make sure that you can understand what I'm talking about. Ooh, it's not on here. So, here we go, the LAD. So this is where you're gonna be able to locate that it's actually that site for that STEMI, right? Okay, so you're gonna see that ST segment elevation in those leads that I had mentioned. And now we're talking about the posterior wall, which is basically right here on the back portion of the left side of the heart. That's the posterior circulation. Now let's go back into that posterior wall. Now for the posterior circulation, the EKG changes that you will be seeing here will be ST segment depression. I'll just put that as ST depression. And what leads you should be looking at for the ST depression? You're going to look for that in leads V1 and V2. Okay. And on top of that, you're going to be seeing tall R waves. Right? And we're still talking about the posterior wall. Okay. And again, the reason that the patient may have a posterior wall MI, it's because of the occlusion in the posterior descending artery. And we are looking into the back side of the heart, onto the left side, right? And here, if there is that ST depression, rather, in leads V1 and V2, and also tall R waves, this is going to give us an idea that there is going to be ischemia, okay? Or possibly injury to the posterior wall. We're talking about the ventricle. All right. So that's about it. I'm going to add some more tomorrow about the EKG. But that's pretty much it about the changes in the electrocardiogram. So don't forget about the anterior wall MI with a STEMI. And we have the posterior descending. It can show us that ST depression, of course, in leads V1 and V2, and that tall R waves. Now let's move forward to the next question here. Question number 4. A patient is admitted to the telemetry unit with severe chest pain that extends to his left arm. The nurse expects which laboratory tests to be ordered to assess heart damage. So we are going to be answering this as a select all that apply. I forgot to put that here. Select all that apply. SADA. The question states, a patient is admitted to the telemetry unit with severe chest pain that extends to his left arm. The nurse expects which laboratory tests be ordered to assess heart muscle damage? Is it A, hemoglobin and hematocrit? Is it B, blood sugar levels? C, CKMB? D, troponin T and troponin I? We have E, myoglobin. F, blood urea nitrogen. I'm seeing Stefan answering C and D. Okay. Judith answered D. Anita answered D. Okay, what about the rest of the class? Okay, I'll wait for a few seconds here. All right, I'm seeing Nijay, Nancy answering C, D, E, and Yukuma answering C, D. Please don't waste your correct answers, guys. Make sure you narrow down all your answers so you can capture all those correct answers. All right. Looking good, looking good, looking good. All righty. Now, let's eliminate the options one by one. All right. Let's take a look on letter A, hemoglobin and hematocrit. Now, before we go to that, our patient still is, the case here is pretty much about MI, okay? And we are going to identify that test that can assess heart muscle damage. This is what we're looking for. What test can do that? Can it determine heart muscle damage? So we'll see. Hemoglobin and hematocrit, of course, eliminate that right away. It doesn't have that capability in determining the damage of the heart. No, it cannot. The hemoglobin hematocrit can only give us an idea if the red blood cell is low or it's elevated or it's normal, okay? So we're only going to use this diagnostic test in order to assess anemia, maybe caused by blood loss, or maybe polycythemia, wherein there is excess RBC. There's way too much. The blood is so viscous, but it doesn't detect the heart damage. Eliminating letter A. Let's go to letter B, blood sugar levels. Well, does your finger stick blood sugar or glucose tell you where exactly the damage is? No, it doesn't. It will only give you an idea that the patient has an elevation or hypoglycemia or hyperglycemia, but will not provide any information where the injury is. Eliminate that as well. CKMB. All right, so here we go. CKMB is one of those tests that can actually tell us that there is now a damage in the heart muscle, and this is heart specific. Okay, cardiac specific enzyme, because we have the creatine phosphokinase, which is pretty much like you have the CKBB, and so it doesn't really the CKBB derivative will not give us an idea if there is a heart muscle injury, but for the CKMB, it is going to pinpoint, lead us into diagnosing or telling us that there is really a cardiac tissue injury. Okay, now if you may recall the normal value of the CKMB, what is the normal value, guys? It is around 0 to 3 nanograms per ml, or it could be the so I'll just use that simply 0 to 3 nanograms per ml. And this is going to, before I'm gonna write some more here, let me remove this so you will have a better picture. And there you go. So we're talking about the CKMB. That way we are gonna be more organized here. The CKMB, like I've said, is cardiac specific. This is going to elevate in 4 to 6 hours after the MI. Okay, again, it will elevate within 4 to 6 hours or after 4 to 6 hours with that cardiac event. Okay, and it will now peak in about 12 to 24 hours. It peaks in 12 to 24 hours, and it will return to normal in 48 hours to 72 hours. Again, the CKMB will elevate 4 to 6 hours after the MI. It will stay elevated, or it will be peaking. The tallest or the highest level of the CKMB level in the bloodstream will be within the 12 hours to 24 hours. Okay, it will return to normal within 2 days to about 4 days. Okay, so it remains elevated for quite some time. Now, we're going to talk about the troponin T and I, another cardiac specific cardiac enzyme, of course. Well, the troponin T and I, we'll take a look here into the value. Troponin I, the value should be less than 0.12, and the unit of measure is nanogram per ml. Okay, and the troponin T, okay, normally it should be less than 0.01 nanogram per ml. Okay, anything above that range, or not range really, but anything above that value, this is going to be a suspicion that your patient might have some cardiac injury. Okay, now thinking about the troponin, this is going to be elevated. It will start to rise. So either the I or the T, this is going to elevate in 3 to 6 hours after the cardiac event. Okay, 3 to 6 hours. Let me rewrite that because you might get confused. Might think that it's 36. 3 to 6 hours after the cardiac event. And it will peak within 12 hours. So it's pretty much going to peak the same as the CKMB, and it will return to normal 9 days. Yeah, that's quite a prolonged. And guys, I've seen so many patients that have had, and it really made my, one of the rotations that I had, not really rotations, but because I've worked in the neurostroke floor in the past, and we've had a huge population of patients that had renal disease. Even we have a stroke floor. Also cardiac problems, neuro problems. And we had this patient that had some bladder cancer. I dealt with this new admission, and his baseline troponins were like skyrocketing. I was like, this is not looking good. They were thinking that it's not cardiac in nature, but I was like, no, it doesn't seem like it's not related to heart problem, because the patient was really manifesting some kind of like chest pain. They were thinking that it was more of like a BPH, and also some issue with his kidneys, right? And I was really trying to convince my charge nurse about this. I was like, I'm not really comfortable taking care of this patient, because the medical provider wasn't really thinking about any cardiac event, because the troponins have been elevated since the admission. And yeah, later on, we found out that the patient really had a cardiac event since the arrival in the ED, which was like 24 hours ago. And so the patient ended up with so many cardiac testings later on, echo, cardiac cath, so many things else, Lexi scan. Yeah, they were able to figure out eventually that the patient had cardiac event other than the kidney injury. And so you really need to be persistent. If the doctor will not listen to you, or the charge nurse will not listen to you, it's going to be challenging. But what you can always do is to make sure that you are notifying the medical provider. This is what my assessments are, and this is the laboratory data that is available, and this is what my interpretation is. If they're not going to listen to you, it's really going to make it difficult. Sometimes you really have to talk to the supervisor as well, in order that you can get another support from the team up until they will get convinced. Yeah, that was quite an interesting shift for me. Now, let's move on to the myoglobin. What is this? Myoglobin. What is this? This is another enzyme that will be released into the bloodstream whenever there is a cardiac event, injury. Supposedly, you should not see any of these enzymes at all. No. Okay? Or it will be lesser than the values that I've said here. Okay? And so with the myoglobin, this is going to be the range, rather. Let me just write here. The normal value for the myoglobin is less than 55 nanograms per ml. Okay. And this is going to be a protein that is found in the cardiac and skeletal muscles. Okay. So it's not really specific just for the cardiac muscle. And even though it's part of the cardiac enzymes testing, it's not really the most reliable enzyme to look for. Okay. Yeah, rhabdo. Because again, the myoglobin is also found in the skeletal muscles. Yeah, you're correct, Stephen. Very good. And so the myoglobin is actually a good size protein that can clog the glomerulus. It can clog there. It can cause renal failure if we are not going to pay attention with the patient's hydration. And so, is the question data? What do you mean? Okay. Yes, SATA. Is that what you're referring to? Yes, it is SATA. I wrote here about SATA, or select all that apply, which I forgot earlier. Okay, let me just put it right there. Page 422. So it will reduce the confusion. 422. Thank you for pointing that out. Okay. Let me go back to my screen here. Let me clear this. Yes, that's select all that apply right there. Okay, so we're talking about the myoglobin. Again, Stephen said that this is also a protein that can be released into the bloodstream whenever there is rhabdomyolysis, which is basically that breakdown of the muscle tissue. Whenever there is an extensive dehydration, it can really clog the kidneys, can lead to renal failure. And again, this is not really specific to the heart muscle alone. So our value for that is less than 55 nanograms per ml. But again, it is not going to be specific to the heart tissue alone. And this is going to be elevated the earliest, guys, which is kind of weird. I don't think it is weird really, but it can elevate within, let's just write it here, myoglobin. It will rise within 30 to 60 minutes after the cardiac event. Yeah, I got you, Chica. No worries. It also will peak within 6 to 10 hours after the cardiac event, and it will return to normal within 12 to 24 hours. But according to all the textbooks and literature and also evidence-based practice, the myoglobin is not really the best indicator, because most of the time the results, I mean the rising, or the by the time when it's starting to peak, especially if the patient is not really within in-house, right, by the time that they get the blood sample, it's already out of the window, right? And so it's not really going to be the most reliable indicator for MI, acute MI. Okay. Now, of course, we have letter F, BUN, blood urea nitrogen. It's only going to help us determine if the patient is adequately hydrated. It will also evaluate adequate kidney function, and also measuring the nitrogen in the blood, which is basically a waste product. And it's not going to be related to the cardiac tissue or cardiac damage. And so we are left off here with the CKMB, the troponin T and I, and the myoglobin. So our answers are letter C, letter D, and letter E. Congratulations for all those who got the 3 correct answers. Now, so you really need to go back to your knowledge base. Make sure you recall those lab tests that will specifically be useful in the diagnosis of MI, okay, especially with damage. And make sure that you can also the creatine kinase is going to involve with the other muscles in the body. Okay, you got the brain tissue, okay, the skeletal tissue. And so the CKMB is actually one of the portions in this creatine kinase testing. It's just a section. It's just a fraction of that, I should say. And again, the CK is not going to, I mean, the creatine kinase, when we are obtaining the creatine kinase, it will also give us the sub readings, right? And so it will encompass those other tissues in the body. If there is any damage to the brain tissue, the skeletal muscle, the heart. So it encompasses all those others. But with the CKMB, it's only limited to the heart muscle, which is basically what we are looking for in this test question. Okay, so I hope that I answered your question. Now let's move on to the next question here. Question number 5. A patient's EKG reveals ST elevation. in leads 2 and 3 and AVF, indicating a blockage in the right coronary artery. The patient inquires rather, which part of the heart is affected. Okay. Let me reread the question. A patient's EKG reveals ST elevation in leads 2-3 AVF, indicating a blockage in the right coronary artery. The patient inquires which part of the heart is affected. How should the nurse respond? Is it A, lateral? Is it B, inferior? Or is it C, apical? Or is it D, anterior? Okay. Don't get confused here. I did not really give all of the descriptions earlier in the EKG. There were some more of that. I limited it to the anterior, the STEMI anterior, and also the depression, ST depression. And so here, the patient inquires which part of the heart is affected. How should the nurse respond? Is it A, lateral, B, inferior, C, apical, D, anterior? What is the answer? You answered letter D. Okay. We got lateral, inferior, apical, anterior. Okay. The correct answer here, it's going to be, well, of course, we have the ST elevation. That's what I have said earlier. 2, 3 leads AVF. But we are talking about the right coronary artery, guys. Please pay attention. We are not talking about the left anterior descending. So this is going to be different from what we have passed through earlier. Okay. Like I've said again, the blockage is not in the left anterior descending. This time it's on the right coronary artery. Okay. So this will probably surprise you. This will probably surprise you now. So if letter A is the answer, if you picked letter A, lateral, what could happen if this is going to be that? Well, the lateral section of the heart will receive the blood from the circumflex artery, okay? We're talking about the circumflex artery. I hope I have a, yeah. So the lateral portion of the heart, which is basically right here, the left side, this is going to receive blood from this coronary artery known as the circumflex artery. And also, it will also receive blood from the left anterior descending artery as well, okay? So we are pointing into this direction, right coronary artery, not onto the left side. If you had answered letter B, let's find out. Why is that going to be the correct answer? Well, when we are talking about the inferior coronary artery, this is basically that artery that supply the lower section of the heart, specifically the right ventricle. This is one right here, the inferior wall. Remember, take a look in here into this section where it's it has that broken lines. Okay, so that is actually on the lower side, close to the backside of the heart, onto the right. Okay, so this is where it says inferior. Now, when there is that occlusion right here in the right coronary artery, this can also lead to MI into the inferior wall. Okay, and the right coronary artery will not supply blood to the left side of the heart. That's why I pointed out that this will really surprise you, because it pretty much has similar findings in the EKG. With the same leads, there will be ST segment elevation as well. But again, we are talking into the right coronary artery in this scenario. And so that is why we're gonna select this letter B, inferior wall MI, because we are pointing out the occlusion in the right coronary artery. And again, the manifestations or the findings that you will see in the EKG will be similar. There's also going to be that elevation of the ST segment and leads to 3 and AVF. Yes, you're going to look for those elevation in those 3 leads. Now, if we are going to look into the apical, which is basically the tip of the heart, okay, the apex right here. This is actually supplied by the same main branch, which is the anterior descending artery. This one right here, the LAD. If we are talking about the apical type of MI. So this gets the blood supply from here, the LAD again. And it doesn't branch off from the right. So that's why this is also a wrong option. Same thing with this. And of course, same thing with letter D, okay? The letter D, anterior wall, gets blood from the LAD as well. So that's why it's going to be an incorrect answer. So I didn't mean to trick you guys, but this is to check if you had some information or if you had knowledge base about the different branches of the coronary artery. So keep in mind that when you have a patient that has an MI into the anterior wall or the lateral side pertaining to the left or the posterior wall, think about the blood supply that is going to be obstructed right here in the LAD, or it could be the circumflex. Whereas if you are thinking about an MI in the inferior wall, this is mostly caused by the obstruction in the right coronary artery. Okay. All right. Let's get moving. Let's go to the next question, number 6. A nurse is managing a patient who suffered an anterior wall. We're back to the anterior wall. Heart attack 2 days ago. During the assessment, the nurse detects a systolic murmur at the heart's apex. What should the nurse do first? Okay. So the question states, a nurse is examining a patient who suffered an anterior wall heart attack 2 days ago. And during the assessment, the nurse detects a systolic murmur at the heart's apex. What should the nurse do first? Is it A, check for changes in the vital signs? Is it B, collect an arterial blood gas sample? C, listen to heart sounds with a patient leaning forward? Or D, perform a 12-lead EKG? Okay. All right, let me reread the question. A nurse is managing a patient who suffered an anterior wall heart attack 2 days ago. During the assessment, the nurse detects a systolic murmur at the heart's apex. What should the nurse do first? Is it A, check the changes in the vital signs? B, collect an arterial blood gas sample? And letter C, listen to the heart sounds with the patient leaning forward? Or letter D, perform 12-lead EKG? Okay, I'm going to wait for your answer here. We're back to the anterior wall MI. All right. So let me go through the selections here. So I'm seeing Yakuma answered letter D, Tablet answered C, Sports 84 answered A. Okay. All right. So let's go through the selections here. Monica answered D, Rodolin D. Okay. Now, guys, we have an add-on in our assessment. Look into the statement here. The patient had an anterior wall MI 2 days ago. Okay. And now that you are the nurse taking care of this patient, you are auscultating. You're able to hear systolic murmur at the heart's apex. So the patient already had an MI 2 days ago, right? So you are now working for this patient after that episode. 2 days passed. Now you are hearing the murmur. You detected that there is that abnormal heart sound, murmur. What you should do is it A, check for vitals or check for the changes in the vital signs. That can potentially be the intervention, guys, because when the patient has an MI, this can lead to the damage of the papillary muscles. Remember those muscles that will actually help out in the proper closure of the valves. And so if there is now a damage in the papillary muscle, then there is going to be that backflow of the blood, especially in the mitral valve right here. Okay. So again, if there is a damage to the papillary muscle as a complication to the MI, it can cause problem into the proper closure of the mitral valve during the systole and also the diastole. So when that happens, if it's not going to close, when the blood is transported from the left atrium into the left ventricle, when the mitral valve, rather, let me just transfer here because it has the mitral valve here. When that blood is in the left ventricle and the mitral valve function is impaired, this will not properly close. And what's going to happen is that the blood, a portion of the blood here can potentially regurgitate. It can backflow and it will now create that murmur, okay? And so with that backflow here, let me just write here, backflow or regurgitation. We're talking about the mitral valve here, guys. So you know, regurgitation. This can be heard as a murmur, an extra sound into the fifth intercostal space. The murmur can be auscultated on the left fifth ICS. Okay? So what is that reason why there is that swooshing sound? Well, of course, the mitral valve is impaired. Like I've said, it's not able to close off entirely when the blood is transmitted from the left atrium to the left ventricle. And when the left ventricle tries to pump in order to push the blood into the systemic circulation, into the aorta, a portion of the blood will flow back into the left atrium. And that is why you can hear the murmur. Okay, again, the site of the murmur will be best heard in the left fifth intercostal space, mid-clavicular line, MCL. Left fifth intercostal space, mid-clavicular line. And this is going to be aggravated, especially when the person is supine. Okay, let me clear my wall here. So the swooshing sound or the murmur will be more heard whenever the person is in a supine position or when they are in the left side lying, because it favors that left side lying position. Okay, don't forget about the location, left fifth intercostal space, mid-clavicular line, and will be much more pronounced if the patient is on the supine or left side lying position. Okay, now I did not end here my discussion. With letter A, checking for the changes in the vital signs. What's the relevance about the murmur? Well, the vital signs can actually reveal the severity of the reduction of the cardiac output. Okay, why is there going to be a reduced cardiac output in this complication about the mitral valve impairment? Well, remember about the backflowing. Instead, that the ventricle should effectively pump the blood into the aorta. Remember about that some amount of blood will go back into the left atrium. So what do you expect? The cardiac output will be lesser this time. Remember about the cardiac output? This, oh, shoot. Let me erase that. Cardiac output. The cardiac output is the total amount of blood that is going to be ejected by the ventricles every minute. And this is going to range from about 4 to 6 liters per minute. I'm not talking just about the left ventricle, but also the right ventricle. So this is the total amount of blood that is going to be pumped by the ventricles every minute, 4 to 6 liters per minute. But when we are talking about the mitral valve impairment here as a complication to the anterior wall MI, this can reduce the cardiac output. So when there is that decreased CO, what can you expect in the blood pressure? Well, the blood pressure will also go down, okay? And because of that decreased blood pressure, the heart rate will now start to elevate. It will be increased, and the respirations will also be increased, okay? And this is, again, because of the decreased cardiac output, okay? Don't forget about that. Now, again, you should be mindful about the vital signs that you will be seeing in this patient. Okay, take a look into those significant changes. Again, you will look for the decreased blood pressure, increasing heart rate, and increasing respiration. So this is a possible good answer. What about letter B? Collect an arterial blood gas sample. Will that help? Well, the blood gas or the arterial blood gas can be useful whenever we have a problem in a patient's probably kidney function or respiratory function. It can interpret, or it can help us determine if there is metabolic acidosis or alkalosis, or it could be respiratory acidosis or alkalosis, but it doesn't really help in determining or diagnosing the heart murmur. It doesn't. So we are going to eliminate the letter B. What about letter C? Listen to the heart sounds with the patient leaning forward. Okay. Well, this option will kind of help with the, it will help you in actually listening more with the murmur, right? Especially with the mitral valve. But again, it will not address the impact of the murmur onto the patient's hemodynamic status. So it doesn't pinpoint to that. It can only help you to listen, to capture that murmur, but it will not really going to help you in addressing the impact of the murmur. Okay, it doesn't. And so let's take a look on letter D. Perform a 12-lead EKG. So we know that the 12-lead EKG can give us better idea on the electrical activity of the heart. It can also give us a better picture if there is ischemia or could be infarction, but it will not provide us information about the mechanical function of the heart valves. Okay, so let me write that down. It doesn't reflect sorry guys, doesn't reflect, I'm just gonna state it. It doesn't give us a information about the mechanical function of the heart valves, which is very critical in this situation because our patient now has the murmur. Okay, it doesn't. The EKG will be able to help us in telling the location of the injury, okay, but not really about the murmur, which is now a revelation that there is an impairment into the mitral valve, and the EKG doesn't do that. Okay. And so I hope that you're able to gain knowledge or insight about the different usability of our tests here. Okay. So yeah, the vital signs can capture that. It's because of the decreasing cardiac output. It can lead into low blood pressure. It can increase the heart rate. It can increase the respiratory rate. So our answer here again is letter B. Yeah. And the situation calls for this one. What should the nurse do first? Let me erase that. So let's go back to the question. During the assessment, the nurse detects systolic murmur at the heart's apex. And the question further asks, what should the nurse do first? It's calling for an assessment skill. And this is something that you can do simply by checking the patient's vital signs. You don't really need to get to the diagnostic tests right away. It's asking for the initial step. All right. So that is the letter B. Oh, I'm sorry. Letter A rather, not letter B. Check the changes in the vital signs. Again, letter A. I got so distracted. Letter A is the answer. Check for changes in the vital signs. That's it. Now let's move forward to the next question. 7. A patient experiencing severe chest pain is being treated with IV morphine sulfate. Which of the following are the intended effects of morphine? Select all that apply. The question states a patient experiencing severe chest pain is being treated with IV morphine sulfate. Which of the following are the intended effects of the morphine? So you will be asked of the therapeutic effects of the drug. So what can the morphine do? Or what are the therapeutic effects of the morphine? Yeah, it's tough. Yeah, it was a tough one. It was a tough one, but don't get fooled by the diagnostic test. It was with that last set of words. What should the nurse do first? Okay, so back to this question number 7. What are the intended effects of the morphine sulfate? What are the therapeutic effects? Is it A, lowers myocardial oxygen demand, or is it B, decreases respiratory rate? C, inhibits ventricular remodeling? Does it do letter D, lower blood pressure and heart rate? Or E, alleviates anxiety and fear? Okay. The patient has severe chest pain, and the patient has been given morphine IV, but you are going to be asked here about what are the intended therapeutic effects. Let's just say that, therapeutic effects, intended effects. So I'm seeing ABE, ADE, ABD, ABE, BDE, ABCDE, ABDE. Okay, all right. Let's take a look on option letter A. Lowers myocardial oxygen demand. I'm seeing a lot of you answering letter A. Very good. Yeah, because when the patient has myocardial infarction, they have that feeling of impending doom, right? That they're gonna die right after that painful episode. They don't know what to do. That really is a stressful situation. The patient here is actually going to need a whole lot of the oxygen because of that blockage. The muscle tissue, the tissue, the cardiac tissue actually is needing a lot of the oxygen, but it's not receiving that sufficient amount of oxygen. Now, the person will get so agitated around this point, okay? They will have that increasing demand for the oxygen. And so the morphine can act as a powerful pain reliever. It can also have that sedative effect. This is going to decrease the oxygen demand by reducing the pain. It will also reduce the pain. It will reduce the anxiety. It can also reduce the O2 demand. Let me put that here as decrease oxygen demand. Because there is lesser pain, there is less anxiety after the medication, or because of that therapeutic effect, there will be a decreasing oxygen demand. So letter A is one of those correct answers. Now letter B, decreases respiratory rate. Guys, I've said about the therapeutic effect, okay? So if you had answered letter B, yeah, I know, the morphine can decrease the respiratory rate. That is one of those side effects, but not therapeutic effect. So this is going to be eliminated. Let me erase that. Whoops. Let me go back. So decreased respiratory rate is a side effect, not a therapeutic effect. Since the question said something about intended effects, not a therapeutic effect. So that's why we are going to eliminate that one. Okay, this one, letter A, is correct. Let's take a look at letter C. Inhibits ventricular remodeling. Hello, Mariama. Okay, so inhibits ventricular remodeling. What is that? The medication itself, the morphine sulfate, it actually will not do that kind of therapeutic effect. The medication that can do that is the ACE inhibitor. I'll just put here ACE-I. Angiotensin converting enzyme inhibitor, such as the lisinopril, okay, or the enalapril. The medication ACE can prevent ventricular or prevents ventricular remodeling. What is that? Okay. Remodeling is basically pertaining to those structural changes that can occur after a myocardial event or a myocardial infarction event. So the morphine doesn't prevent. So let me just write down here. Myocardial or the ventricular remodeling. So in order for you to get clarification, ventricular remodeling pertains to those changes, structural changes in the myocardium after the MI. Structural changes. Let me just put here triangle with an S. Structural changes. Okay. Ventricular remodeling, I said, it's pertaining to the structural changes in the myocardium after a heart attack. And this is only going to be prevented by the medication ACE inhibitor. Okay. It will not be achieved by the morphine sulfate. And so we are eliminating letter C. Okay. What about letter D? Lowers blood pressure and heart rate. Let's take a look. Is this going to be a therapeutic effect? Yes, because when the patient is in pain, when the patient is having chest pain, let me just write down CP. then it can stimulate the sympathetic nervous system, SNS stimulation, which can lead into increasing blood pressure, right? And also, it can also lead to more anxiety, especially with the SNS stimulation, sympathetic nervous system stimulation. It will lead into the blood pressure. And so, with letter D, lowers blood pressure and heart rate. It can do that therapeutic effect. We want to make sure that the patient's pain level is addressed in order to decrease the blood pressure. It can also decrease the heart rate. Okay, so that is why letter D is one of those answers. And I'm seeing, okay, not all, but at least I'm seeing letter D as one of the answers. Now, what about letter E? So let me clear this. This is correct. This is correct. But this one is incorrect. This is incorrect. What about letter E? Alleviates fear and anxiety. Yeah. Actually, that is one of the therapeutic effects of the morphine sulfate, having that chest pain. It will reduce the anxiety, it will reduce the fear, and it can really decrease significantly the chest pain. All right. And so with that, it will also cause a drop in the oxygen demand. It can also reduce the blood pressure. It will reduce the heart rate. Okay. But like I've said earlier, you got to be careful here as you're being asked about the intended or therapeutic effect. This is not our intent to decrease the patient's respiration, although the patient will manifest that side effect, but this is not really the primary reason that we are administering the morphine to this patient. Okay, so guys, please watch for those words that will kind of make the statement kind of erroneous, or maybe it will trick you into believing that you have the correct answer. But yeah, you can always look for those keywords. Let's say intended effects, therapeutic effect. Okay, so that is just one of the clues that you should be looking out for. Okay, let's move on to the next question. Number 8, a patient. Oh, before I'm gonna go do that. So guys, again, we are promoting our NCLEX review course at a website, www.stancoast-nclex-coaching.com. We are open. Make sure that you are going to enroll, and so that you will be able to enjoy our interactive lectures as well, and make sure that you can get access to the library that we have. We have about 3,000 NCLEX-style questions plus 200 NGN test questions and more mock exams. And also we have so many other study guides that we can give you. And so make sure that you enroll as early as you can. All right, let's go back to that scenario. Where am I at? So I think we are here. Number 8, question number 8. A patient is admitted with a heart attack and atrial fibrillation. While listening to the heart, the nurse observes an irregular rhythm and detects an extra heart sound at the apex after the second heart sound, S2, okay, which remains consistent during breathing. How should the nurse document these findings? Again, the question states, a patient is admitted with a heart attack and atrial fibrillation. While listening to the heart, the nurse observes an irregular rhythm and detects extra sound at the apex after the second heart sound, S2, which remains consistent during breathing. How should the nurse document these findings? Is it A, irregular heart rate with S3, or B, irregular heart rate with S4, C, irregular heart rate with aortic regurgitation, or D, irregular heart rate with mitral stenosis? How should you document these findings? Is it A, irregular heart rate with S3, or B, irregular heart rate with S4, or C, irregular heart rate with aortic regurgitation, and D, irregular heart rate with mitral stenosis. And I want you to pick those significant assessments here. Extra sound at the apex. After the second heart sound. The heart sound, S2, is normal, but there is that extra heart sound in the lower part of the heart that kind of follows after the S2. And your patient has an irregular heart rate, atrial fibrillation. So not just MI, but has AFib. And this is really going to be the characteristics of patient that we will be having in the real life. They just don't have like one problem, but they're going to have multiple problems. And so this is going to make your assessment quite challenging, guys. Yeah. So I'm seeing answers here. Letter A. All right. Wonderful. Letter A. Okay. So let's take a look into the option A. Irregular heart rate with S3. Well, the S3 sound, let me write it down here. S3 is actually heard early in the diastole. This is something that you can auscultate early in the diastole when the patient's heart relaxes. Okay? So that is the S3 sound, extra heart sound. Okay? So what causes the S3 sound? Okay? This is going to occur when the mitral valve and also the tricuspid valves, or known as the AV valves, okay, atrioventricular valves, will open and it will allow the blood flow into the ventricles, okay? So this S3, again, will be heard early during the diastole, and this is caused by, of course, just the regular movement of the blood, but the movement of the blood from the atrium and into the ventricle. Okay, so that is the correct answer. So let me just mark that as a correct answer. What about letter B? Irregular heart rate with S4. What is that? Well, an S4 is going to happen late in the diastole. So take a look into the difference in S3 and S4. While S4 can be heard during the late portion of the diastole, the S3 can be heard early during the diastole. And this is going to be heard in patients with atrial fibrillation because of a disorganized atrial contraction, okay? Now, do you think that S4 would match to the scenario that we just read? An extra sound at the apex after the second heart sound. Remember that the second heart sound basically is the closure, and also this is the time right after or when the heart relaxes. And so that is going to fit into our option, letter A. So B is wrong, letter A is correct. What about letter C? Irregular heart rate with aortic regurgitation. What is that? The aortic regurgitation is what we call as that diastolic murmur. Diastolic murmur. So this is characterized as blowing sound. It's also going to be a high-pitched sound. And basically the diastolic murmur, it's caused by the blood flowing back from the aorta into the left ventricle. So let me draw that so you will be able to give a better picture of what I am talking about. So let me point this out. Aortic regurgitation. Let me have another heart. And it pertains to the aorta, of course, the valve as well. Okay, so that high pitch sound is going to be generated once the blood comes back from the aorta into the ventricle. Okay, this is the left ventricle here. And remember about the aortic valve right here. And so if there is aortic regurgitation, basically that means backflow. Okay, the blood that has already passed through the aorta will have a chance to go back into the left ventricle. And so this is going to be detected as a very high pitched, that blowing diastolic murmur because of its high pressure. This area of the side of the heart, the left side, and also the aorta, it's very high in pressure. That is why it will lead to that blowing high-pitched sound. But then again, this is not going to relate into the scenario that we are being asked, because the aortic regurgitation sound or the murmur actually will occur immediately after the systole, or not systole, but the S2 rather. Okay, so again, this is going to occur immediately after the S2. Not early in the diastole or not late in the diastole, but it's actually immediately after the S2. So it's not going to fit that characteristic. What about letter D? Irregular heart rate and mitral stenosis. So where is the problem with mitral stenosis? It's going to be in the atrioventricular section right here. If there is stenos, then the blood coming from the left atrium is not going to be fully ejected or transported into the left ventricle because it's kind of stiff. Okay, so it will allow some portion of the blood to go into the left ventricle, but not all of the blood. Okay, so it is again stiffening of the mitral valve. What am I talking about? Yeah, mitral stenosis. Yes, stiffening of the mitral valve. Stiffening of mitral valve. Again, this will not allow full transport of the blood coming from the left atrium into the left ventricle because of the leaflet that is quite stiff. Okay, and with that, because the leaflets are quite stiff, it will also lead into backflowing of the blood into the aside from the regurgitation, or aside from not allowing fully the blood to go into the left ventricle, it can also lead into that high-pitch rumbling sound, rather, I should say. High-pitch rumbling sound. Okay. So again, the passageway here is narrowed. So supposedly, when the heart relaxes, this will allow the left atrium to transport the blood into the left ventricle. But again, this is very stiff. And so this will cause that rumbling sound, narrowed mitral valve. So this is going to be very easily detected as well. So what you're going to do here when you're assessing the patient, you're going to be using the bell of the stethoscope for that mitral stenosis. Bell of the stethoscope. Okay, so yeah, looks like kind of heavy, guys, but these are all essentials, especially in the assessment of the murmurs. If you are lacking the knowledge base about the murmurs, I highly recommend that you go back into the assessment, because this can be asked in so many other heart problems, especially with mitral valve prolapse, aortic regurgitation, stenosis. You will be asked and you will be battered with all these tough questions. So I highly recommend that you go back into those assessment skills and techniques. Now let's move forward, guys, with the next issue or next. Oh, okay, here we go. I forgot to talk about this. This is going to be the exact sites where we are going to listen to the murmur. Okay. And when you are listening to the apical sound, let me enlarge this. Okay. Can you see the APTM? I always call this as the APE team. So when you are auscultating the patient's chest, okay, if you want to assess better the aortic valve, you're going to have to point your stethoscope or apply the stethoscope in the mid-sternum, and of course in the level where it's close to about third intercostal space. I mean the same level where the third intercostal space, but it's on the sternal area. Then you have the pulmonic valve right here that you can hear towards the left sternal border. You have the tricuspid section right here where the T is. You will be able to hear the tricuspid valve about the fourth, 1, 2, 3, 4, or fifth intercostal space to the left sternal border. That is where the tricuspid, and then you have the mitral valve. You can best hear that towards the apex of the heart to the left side, and this is going to be close to the fifth intercostal space as well. So don't forget about those usual sites that we should be assessing for those valves. Okay, again, the aortic valve, the pulmonic valve, the tricuspid, and the mitral valve. So don't forget about these basic areas where you should be auscultating. Now let's move forward into the next question here. Question number 9. An elderly patient had a heart attack 3 days ago. At 11:30 a.m., their blood pressure was 104/62. The nurse's notes at 1:30, or hang on, let me reread that. An elderly patient had a heart attack 3 days ago. At 11:30 a.m., their blood pressure was 104/62. The nurse's notes at 1:30 p.m. include urinary output of 90 mLs over the last 4 hours, capillary refill time of 3 seconds, blood pressure of 99/70, and cool extremities. After reviewing these observations, what should the nurse do first? Don't forget that you're being asked of what would be your initial action. Heart attack 3 days ago, right? The blood pressure at 11, or their blood pressure was 104/62 at 11:30 a.m. And at around 1:30 p.m., the nurse's notes reveals urinary output of 90 mLs per hour, or 90 mLs rather, over the last 4 hours, and then cap refill of 3 seconds, blood pressure of 99/70, and cool extremities. What should you do first? Is it A, administer a fluid, challenge, or bolus? Or is it B, inform the healthcare provider immediately? Or is it C, help the patient walk? Or is it D, give Lasix as prescribed? I'm seeing letter A's and 2 B's. Okay, I'm seeing Sports 84 answering B, and also Mariama. Okay, now I really want you to think critically here, guys. Patient had MI 3 days ago. So think about the possible complications that have already set into our patient. Complications. because what you're seeing here are the changes in the vital signs. Look at those vital signs. Comparing the vital signs at the vital sign, or the blood pressure rather, at 11:30 a.m. The blood pressure was what? 104 over 62. Later on, at 11:30 a.m. Oh no, is it 11:30? 1:30. Let me erase that. At 1:30 p.m. Oh my goodness. Sorry about this. 1:30 p.m. At 1:30 p.m., the blood pressure is now at 99 over 70, and the urinary output is 90 mLs for the 4 hours. And cap refill is what? Is 3 seconds. I don't like these assessment findings. And there's also cool extremities. Okay? These are significant changes in your patient. Even though it doesn't look too low as far as the blood pressure, and the urine output of 90 mLs in 4 hours, remember about the urinary output that should be at least 33 mLs per hour. This is our lower limit, okay? Anything below 30 or 33 mLs per hour, that is already considered oliguria, okay? And this has already been 4 hours, and the patient only had 90 mLs. What is that? 90 mLs divided by 4 hours. So that is only 22 mLs per hour? Yeah, that is already oliguria, guys. Not good. So you're answering letter B. Okay, let's find out. Letter A. What is in letter A? Administer a fluid challenge bolus. I'm seeing your answer, Bethany. Letter A. Administer IV bolus or fluid challenge. Do you think that this is appropriate care? Is this going to be unexpected, or is this going to help the patient, or is this going to harm the patient? Bolus is actually delivery of IV fluid. It could be saline, and this is going to be delivered really rapidly, and this is going to add some more volume into the vascular compartment. It will increase the blood volume. And if your patient has a possibility of a complication setting in, do you think that this would be therapeutic, or will this harm the patient? Well, a bolus in this scenario probably will not be helpful, okay? It might be considered if we are just thinking about the urinary output that is low. Yeah, if we are just thinking about the urine output that is minimal, okay? However, because the patient has MI 3 days ago, the bolus can increase the workload of the heart, okay? It can increase the workload of the heart. It will overwhelm the ventricle. It will not help. Workload. Increase cardiac workload. Let me just put heart in there. So this bolus will only help to cause, let's say, if we are just addressing the urinary output. But guys, again, look into the history of our patient with the MI and the possibility of left-sided heart failure. This will not help the patient. Now, what about letter B? Inform the healthcare provider immediately. Yeah. That is the correct answer. Why? Of course, you are seeing that there is a deviation into the patient's assessment. The blood pressure is going downhill. There is hypotension. That simply means that there is now a decreased cardiac output. And the cardiac output will decrease if there is left-sided heart failure. I hope that you can recall that, guys. And so when the blood pressure goes down, when there is now a decrease in the urinary output 90 mLs in 4 hours, that's very minimal. So that is oliguria already. That means that the kidneys are not getting enough blood. Okay? And as we recall, guys, the kidneys should receive 20% of the total cardiac output every minute. And that's going to amount about 1,200 mLs per minute. That's a lot. But 90 mLs, that's a huge reduction. So that is a big change. Notify the medical provider. And the cap refill of 3 seconds, that is very significant as well. That simply means that there is no longer enough perfusion and also circulation into the nail beds, the peripheral portions of the body. So these are significant findings. Aside from that, I think I forgot to put here cool extremities. Okay, yeah, we have the cool extremities. That's a significant finding, guys. So you need to report those immediately to the medical provider. That is why that is the answer. Now, if we are going to answer here, letter C, help the patient walk. Do you think that would be appropriate for the patient at the current time when they have low blood pressure and with what else? Cap refill of 3 seconds, cool extremities? The ambulation can actually will overwhelm the heart as well. It will increase the heart rate. It will also increase the oxygen demand. It will also further cause ischemia into the muscles, and it will worsen the patient's infarction. So we're not supposed to do the ambulation at this point because of those assessment findings. Now, if we are answering letter D, give Lasix as prescribed. Kind of like tempting, right? Remember about my lecture about the fluid overload and administration of Lasix? Kind of tempting to give that answer, but this is going to be inappropriate around this time. Why? Because the patient already has a low blood pressure. Remember, there is already a low cardiac output, and the therapeutic effect or the intended effect of the Lasix is to decrease the fluid volume in the vascular compartment by allowing the kidneys to pull all those extra fluids, urinate all those extra fluids. But around this time, I don't think we have way too much fluid in the system. And remember, guys, that the Lasix can also cause a drop in the blood pressure. So instead of helping the patient around this time, if you're going to give the Lasix, it's going to compromise the patient's remaining heart function. Okay, it will decrease the cardiac output all the more, will decrease the blood pressure, and again, it will cause more harm than good to our patient. So it will be inappropriate. We don't want that. So we are gonna select letter B. Inform the healthcare provider immediately. And let me underline, we are asked about what should the nurse do first. Okay. Do you think that this is a very like a life and death scenario? Not quite. Okay. It's not like between life and death yet. You will see that there is already a significant drop, but it doesn't really call for like those ABCs, like very urgent. No, it doesn't. So you can do your assessment here, and also you can notify the medical provider after you had collected your abnormal findings. So make sure that they know right away that these are the significant changes, so they can give us those important medication or treatments. Okay, so our goal here in this test question is for you to prioritize those critical signs and make sure that you are prioritizing those urgent. It's not really life-threatening, but urgent. prioritizing critical signs, and make sure that you are preventing any more of deterioration in this patient. Okay. And again, the main issue in this scenario is the decreased cardiac output. And why again there is a reduced cardiac output? That is because of a result to the left-sided heart failure. The weakening of the ventricle, it's no longer able to pump the blood out from the ventricle into the systemic circulation. So the blood pressure will also start dropping. It will also lead to decreased tissue perfusion. And when we are talking about reduction of the cardiac output, think about the reduction of the blood supply to the organs, to the brain, to the kidneys. And that is why the patient has oliguria, because of the reduced blood supply to the kidneys. There is oliguria. All right, let's move on to the next question. Question number 10. A nurse is evaluating a patient who had a myocardial infarction. The nurse observes the cardiac rhythm on the monitor, which is this one. What action should you do at this point? Is it A, inform the medical provider, B, activate the rapid response team, or C, check the patient for rhythm changes, or D, administer lidocaine as ordered? Take your pick. What is your answer? Okay, let me read the question. A nurse is evaluating a patient who had MI. The nurse observes the cardiac rhythm on the monitor. So what is that rhythm? What action should the nurse take? Is it A, inform the medical provider? Is it B, activate a rapid response? Or is it C, check the patient for rhythm changes? Or D, administer lidocaine as ordered? I'm seeing Chica answered B, Bethany and Naomi answered C. Okay, let's go through the selections here, guys. Letter A, inform the medical provider. Are you supposed Mariama asks, is that a PVC? Yes, that is a PVC right there. Premature ventricular contraction, which is only one. Sinus rhythm with PVC. So, are you supposed to call the medical provider right now for a single PVC? Probably not a good step to do, okay? Well, let's define first what is this? The PVC. Premature ventricular contraction. Look at that. There is widening of the QRS complex and that peak right there. It looks like the tallest building in the world, Burj Khalifa, right? Yeah. So, what do you mean no? So here, what is this? This is basically a premature ventricular contraction. What is a PVC? So if you are lacking knowledge base about the PVC, I need you to pay attention. Premature ventricular contractions are irregular early heartbeats. Early heartbeats. And they are originating in the ventricles. Originates in the ventricles. Okay, so that is the simplest definition about PVC. It is a abnormal appearance of that early heartbeat. And this is going to occur, it will come from the ventricles. And so this is going to occur before the regular heartbeat, okay? And it will now cause disruption in the normal rhythm. And also it will cause some problems later on. So looking into just one PVC, yeah, if this patient probably was previously normal sinus rhythm, and then all of a sudden this is appearing, you would be like, huh, what was that? It suddenly appeared. And guys, remember about the possible complications that can occur into our patient after a myocardial infarction event. They will probably gonna manifest those deadly arrhythmias. So the presence of PVCs would be enough for you to be alerted, okay? If this is not happening before the myocardial event, yeah, I would be on my toes right now. Something could possibly happen in this patient in the next few hours. So the PVC basically is going to be described as wide QRS complexes, wide QRS, and this is going to be wider than the 0.12 seconds. Okay, look at that duration right there compared to the regular sinus rhythm. That is pronounced widening, okay? There is widening the QRS, and then in the PVC, there is no preceding P wave. No, there's none. Because when you're looking into this EKG strip, that is the P, that is the P, this is the P here, another P, another P wave. However, you don't see a P wave here because this is not a P wave. This is the T, T wave right here. That's the T. This is the T as well. So you don't see that P wave in this section right here where there is a widening. So again, this will give you a clue. In the PVC, there is widening of the QRS. There will be no preceding P wave. No preceding P wave. Okay, so that is the characteristic of the PVC. Now, or it could be buried as well in the QRS, but in this strip, we don't see it. We just don't. Now, the QRS will also going to be followed by compensatory pause, like this one right here. Look at this. That is a very lengthy pause right here. That you can see a straight line. So this is what we call as a compensatory pause. That is going to follow after the premature ventricular contraction. So this will allow the heart to reset. Now, there's also that T wave changes. So look at that T wave right here. It's actually on the opposite direction. Instead of going up, it is going down. So let me add to the QRS right here, wide QRS. There will be no preceding T wave, and there is also T wave change. And the T wave is pointing downwards, okay, in the opposite direction. Now, guys, we're only seeing a solo premature ventricular contraction. So this is considered benign, okay? Again, if it's only single PVC in a minute, it is considered benign, especially in the healthy individuals without heart disease. It is benign. However, if the PVCs will be more frequent, let's say, for example, it can be about 5 to 6 consecutive PVCs in a minute. I don't like that. Let me write that down. If you're going to have consecutive PVCs, let's say about 5 or 6 in a minute, then this is concerning because this can be considered as a ventricular tachycardia already, if it's consecutive, right? We really need to keep an eye on this patient. we need to treat this patient right away. It could lead to a more serious arrhythmia. It could lead to VTAC. It can lead to ventricular fibrillation. Now, let's identify what causes the premature ventricular contractions. Erase. What are the causes of PVCs? Many. There are many of them. So one of the causes here is the MI. Okay, our patient had MI. In some settings or scenarios, this can be caused by an electrolyte imbalance as well. For example, if there is abnormal potassium level, electrolyte imbalance, hypokalemia, hypomagnesemia. Okay, so this will cause the heart muscle to be very irritated. Okay, and you need to address that as soon as you figure out, hey, our patient's magnesium and potassium levels are out of whack. We need to correct that one. Or it could be caused by stress. Okay. Or it could be caused by caffeine, alcohol, or certain medications that may trigger the PVCs. Or it can be caused by maybe cardiomyopathy, which is another issue. Or it could be caused by heart failure. Or it could be valvular heart disease. So there are so many things that you can think of that will be associated with the premature ventricular contraction, valvular heart disease. Or, for example, if the patient is hypoxic, low oxygen level. So let me add to that as number 7, hypoxia. Okay, so these are the known causes for premature ventricular contractions. So again, our focus here is on a patient with MI. So what are you going to do here? Is it A, inform the medical provider? Was it appropriate? Let me see your answers. A, there's B, and C. Yeah, okay. So informing the medical provider right that time when you are seeing the one premature ventricular contraction, it will not going to be appropriate, okay? What are you going to do here? Okay. It can be necessary though, if there is now changes, if there are more changes in the EKG, if the PVCs will be more frequent or more concerning, then that's the time that you need to talk to the medical provider right away. But again, for a single PVC, it's not a priority. Now, what about letter B? Activate the rapid response. Yeah, the rapid response nurse would love you for calling her. No, just kidding. You're not supposed to activate the rapid response at this point yet because this is not an urgent situation. It doesn't require immediate intervention. So do not activate the rapid response at the moment, okay? Now, if you answered letter C, check the patient for rhythm changes. Yeah, that's the correct answer. Because when you are going to see a preliminary or initial change in the rhythm, let's say the appearance of one PVC, yeah, you will be compelled to, hey, I need to keep an eye on this patient. And you're going to instruct your monitor technician. Can you please let me know if this is going to occur most frequently? Because I really want to know ahead of time. Yes, you got to make sure that you're able to capture any changes or any worsening or any more developments of a PVC, because like I've said, this is going to be a precursor to more serious arrhythmias when they become frequent. So this can lead to VTAC. It can also eventually lead to ventricular fibrillation. That is why we have to do letter C. Okay. What about letter D? Administer lidocaine as ordered. Is it appropriate to administer lidocaine around this time? We know that lidocaine is antiarrhythmic. Let me just write that one. Lidocaine is antiarrhythmic. But this is going to be intended only when there is now frequent or much more dangerous type of arrhythmias. So with a single PVC that you're looking at right now, it doesn't really justify the immediate administration of the lidocaine. It doesn't. All right. So back to the correct answer, we are going to check the patient for rhythm changes. Make sure that you keep an eye into the cardiac monitor. And aside from that, on top of just monitoring, you will have to intervene as well. Okay, you have to find out what could have precipitated the premature ventricular contraction. Okay, so again, look at these causes. Could be caused by MI, could be caused by electrolyte imbalance, could be caused by stress, could be caused by heart failure, hypoxia. So if you're going to assess your patient further, if you're going to see that your patient probably has some low oxygen saturation, maybe 88, 85% on room air or 85% on 2 liters, yeah, that's a huge concern. So there is now a problem with the circulation here, hypoxia. So you need to address that. Address the root cause. If there is a problem with the electrolyte, potassium, magnesium, if they are very low, that might need to be replaced. So get an order for PRN replacement in order to prevent this PVC to occur more. Okay. Now the others, cardiomyopathy, valvular heart disease, most often what you're going to do here is to treat the patient symptomatically. All right. So that is all about the premature ventricular contractions. And this is quite simple, guys. There's more, like the bigemini, trigemini, quadrigemini, and we will talk a little bit more of those in the next sessions. Now let's move forward with the next question. A client hospitalized for a myocardial infarction develops cardiogenic shock and receives an arterial line or ART line. Which prescription from the healthcare provider should the nurse double check before implementation? Again, let me repeat. Excuse me. A client hospitalized for a myocardial infarction develops cardiogenic shock and receives an arterial line. Which prescription from the healthcare provider should the nurse double check before implementation? Is it A, notify provider if urine output is less than 30 mLs an hour for 2 consecutive hours? Or is it B, administer metoprolol, 5 milligrams IV push? Or is it C, prepare for insertion of a pulmonary catheter, pulmonary artery catheter? Or D, titrate dobutamine or Dobutrex to maintain systolic blood pressure above 100 mmHg? Okay. Take your pick, guys. What you should do here. Which prescription from the medical provider should the nurse double check? It simply means that you need to verify that you are questioning, that you are not quite sure if the order is going to help the patient, or you are questioning the order maybe because the medication order or the treatment order is going to harm the patient. Okay, so that is what is this question is all about. So what is your answer? Is it A, B, C, D? And guys, our situation here points out that the patient has cardiogenic shock. So this is actually in the midst of the chaos. Cardiogenic shock is a life-threatening condition. You're actually in the midst of the chaos here. You're trying to do everything what the doctor has ordered for you to do. So we have Mariam answering letter D, titrate Dubutrex to maintain systolic BP above 100 mmHg. Okay, don't get confused, guys. It's asking for you to question which of the orders that you should question. Double checking, basically. The word double check, it's something gonna alert you, hey, I don't think this is something that I'm not quite sure about. I don't think that I have to immediately give this. I just need to think over. I have to make sure that what I'm going to do right now will not cause harm to the patient. So, all right. Jared Steele answered B. Yeah. Bethany answered also B. Nargiza answered C, Tableya answered B, Mariama answered D, and Rodeline B rather. Hello, Jared. Okay, so let's go through the selections here. Notify the provider if urine output is less than 30 mLs. Is this something that you need to double check? I guess not. No, of course. This is going to be a good prescription, right? So there's nothing to question about this. It said that the doctor's order that you will have to let the doctor know if the patient's urine output is less than 30 mLs for 2 consecutive hours. So it's actually telling you, hey, let me know, call me if the urinary output goes below 30 mLs per hour. So that is a good intervention. You don't need to question that one. This is a good order. So we are eliminating that because we are looking for that order that can cause harm to the patient. So let me just put it here. What are you looking for? Look for the prescription. Let me just put RX there. That can harm the patient. That you should question. Okay? So letter A, of course, that's a good order. So if you're going to answer letter B, administer metoprolol 5 milligrams IV push. Now, before you answer, you have to recognize what metoprolol is. Okay, as I have said in the past, metoprolol is a beta 2 adrenergic agonist, or simply beta blocker. Oh no, beta 2 adrenergic antagonist, excuse me. Antagonist. Yeah. So, remember about the effects of the beta adrenergic antagonist? So, in order for you to understand, let me throw in some pharmacological caricature here. All right, let me erase this. So that is a beta 2 adrenergic antagonist. So I need more space. Let me erase this. What is the role of the beta blocker? Yeah, it does work a lot of stuff. So for example, this is our receptor. Beta 2 receptor. So that basically is the endpoint where the norepinephrine or epinephrine should attach. Okay, so for example, in the normal physiology, NE stands for norepinephrine, or E, epinephrine, or noradrenaline or adrenaline. So when the body produces the norepinephrine, noradrenaline, this will attach into the beta 2 receptor. Okay, so let me just put here NE attaching to the receptor or the epinephrine. Once those neurotransmitters will attach to the beta 2 receptors, this can cause an elevation of the blood pressure. There will be vasoconstriction. Okay, vasoconstriction. However, if we are giving them the beta blocker, okay, let me erase this partially here, erasing this partially. If we are giving the patient the metoprolol, which is a beta blocker, metoprolol, this will now fit into the receptor. It will attach to the receptor. And once this happens, when the norepinephrine starts to stimulate the receptor, or once it tries to attach to the receptor, it can no longer do that. It's because the blocker has already attached to the receptor. So it will render the norepinephrine and epinephrine powerless. Even though if you have a lot of adrenaline or noradrenaline, I hope we were right, y'all. Yeah, I'm just giving you a little bit of introduction, so I hope that you will be able to understand the mechanism why the metoprolol is helpful in preventing the hypertension. Yes, it blocks that receptor. So the norepinephrine and epinephrine will no longer be able to attach to that receptor. So the patient will no longer have elevated blood pressure. The patient will have a lower blood pressure. So just a simple explanation about that. Okay. Now, in here, our patient has MI, right, with cardiogenic shock. When we are talking about cardiogenic shock, always recall about the cardiac output. Always do that. When there is a reduction of the total cardiac output, there is also going to be hypotension, low blood pressure. If there is low blood pressure, what do you expect in the perfusion of blood into the organs? Of course, it will be compromised. The blood supply in itself to the heart will be decreased. The blood supply to the kidneys will be decreased. The blood supply to the liver, the brains, and everywhere else will be decreased. And so, if we're going to give metoprolol in a patient that already has cardiogenic shock, do you think it will help? No, it will not. It will cause more complication. So we are going to get rid of this order. We're going to have to question this one. This is unsafe for this patient. That is the correct answer. Shock plus reduced BP sounds bad, but it being cardiogenic, I'm not certain if I'm correct. You were correct. Yeah. So the addition of the metoprolol in the medical provider's order, like I've said, if you think that the patient now has an onset of decreased cardiac output, if the patient now has low blood pressure, do you think that you're going to give a high blood pressure antihypertensive to a patient when their blood pressure is low? Of course not, right? No, of course not. You're not going to administer an antihypertensive medication when the blood pressure is low. You don't. And of course, when this patient has I think this is going to be a patient that has a developing left-sided heart failure. The administration of metoprolol is not safe because it can also decrease the contractility of the heart muscle. It has that negative inotropic effect. Negative. Oh boy, my handwriting sucked. Not just today. Negative inotropic effect. It actually will decrease the contractility of the heart muscle. Negative inotropic effect. Okay? So it will weaken the heart muscle from pumping. So it will not be able to really push the blood out from the heart into the circulation. So it has that negative inotropic effect, which is the exact opposite of digoxin. Remember about the digoxin? It will enhance the contractility. So opposite, it is going to be positive ino. But here, With the metoprolol, it has negative inotropic effect. It will weaken the heart muscle, and it's not supposed to be given in a patient in a cardiogenic shock or in a developing or a decompensated heart failure. Very good. Very good that you got the letter B correct. All right. Wonderful, guys. That's what I like. You need to really make sure that you understand the mechanism about the medication and the complication that will develop after a cardiogenic shock. That's what I want you to understand here. So good job. Now let's talk about let me erase this because it's getting messy. What about letter C? Prepare for insertion of a pulmonary artery catheter. Do you think that this is a bad order? Is this an order that could help the patient, or is this a bad order? Well, the insertion of a pulmonary artery catheter, or known as the PAC, P-A-C, this is actually going to give us a better understanding about the hemodynamics in the patient. This is going to involve the insertion of that catheter, and it will give us the different values, the pressures inside the chambers, and it will give us some more understanding on how to treat the patient. So we don't want to question this order. So we're going to eliminate this one. Okay, what about letter D? Titrate dobutamine, Dubutrex, to maintain systolic BP above 100. Yeah, Dubutrex is an inotropic agent. So this will help maintain that blood pressure as well. It is going to improve contractility of the heart muscle. Contractility is increased. Yeah. So we are going to make sure that we are going to do that as well once we receive the medication order, dobutamine. Okay. Now, where are we at? Okay, I think that's pretty much it. So if I am going to just simplify the different interventions here, or not interventions, but medication orders, notify provider if urine output is less. This is going to be helpful. Administer metoprolol, not helpful. And letter C, prepare for insertion of a pulmonary artery catheter. Yes, it will be helpful because it will help us know the different pressures inside the chambers of the heart. And titrating the dobutamine will actually improve the contractility when we are maintaining the systolic BP as well, the blood supply to the major organs in the body, plus that inotropic effect, it will help the patient. So guys, these are your assessment for the answer. So we are going to have to question the patient's or the doctor's order to administer the metoprolol. This is something that can harm the patient. So guys, I know that you really wanted to look for those NGN questions, right? Like the bow tie, the multiple select, or the matrix. I know that you really are looking for those test questions. But if you don't have the capacity to do your critical thinking, even with the multiple choice, then you will not be able to move forward from that. So start with the multiple choice because it will always be there. And actually with this, just with a simple analysis, it can help you determine what interventions can be harmful or helpful, or what those procedures might be expected or unexpected. So don't neglect those multiple choice because these are actually the basics, the foundation of the like understanding the complexities of the nursing interventions and medication orders. All right, let's move forward here. But good job with your answer. Now the question here is, a nurse is evaluating a patient who recently experienced a myocardial infarction. Reviewing the electrocardiogram strip below, the nurse identifies the rhythm as A, sinus tach, B, premature ventricular contractions, or C, ventricular tachycardia, or D, atrial fibrillation? Take your pick, please. I think this would be easy. A nurse is evaluating a patient who recently experienced a myocardial infarction, reviewing the electrocardiogram, EKG strip below. The nurse identifies the rhythm as A, sinus tach, B, premature ventricular contractions, C, VTach, or D, atrial fibrillation. That's an easy EKG. Very easy. Letter A is the correct answer. This is sinus tachycardia. That is the correct one. Well, what are the characteristics of sinus tach? Well, I think everyone sucks at telemetry. Yeah, don't feel bad. Everyone is learning here. All right. All right. So the patient has sinus tachycardia. So what are you seeing here is that there is regularity, there is uniformity in the intervals. Actually, your patient rate at this time is exceeding 100 BPMs, 100 beats per minute. Okay. All right. Greater than 100 beats per minute for that sinus tachycardia. And this is going to originate in the sinoatrial node, SA node, sinus tachycardia. And of course, this is going to be characterized by a P wave. There is still a P wave. You are seeing the P wave here. Here's another one, and so forth. Yep. You see them. There's QRS, normal complexes, but just that rapid beats. Okay. Okay. Well, this is going to be again, like I've said, sinus tachycardia is basically characterized by that rapid beat, 100 exceeding 100 beats per minute. It is going to be seen with a P wave. It's not absent. There is still QRS. What you're going to do here is you're going to have to count for the R's, okay? And in a 6-second strip, all right? And if you are going to determine the differentiation here with the PVCs, remember about the PVCs, there is widening of the QRS, and there is also the absence of the P wave, or it could be hidden. So we're eliminating the PVC at this point. We don't see the widening. There's no widening. It's very narrow right here. There's no widening. There's no ventricular tachycardia either. You don't see that. And atrial fibrillation, you don't see atrial fibrillation because there is presence of P waves. Because atrial fib is characterized by the absence of the P waves. Now, going back to the VTach. The VTach is also described as widened QRS. What's 1144? Widening of the QRS. And there is also rapid heart rate with that bizarre. And you're not going to really see those, the complex, okay? Now, moving into the strategy here, what are we going to look for? We're going to have to look for the normal versus abnormal findings. So again, first is to understand the characteristic features of the heart rhythm on an EKG. It's not a 6-second strip. This is way too much. The patient's rhythm here, you need to understand the physical features here, especially with the sinus tach. You have to differentiate whether there's widening of the QRS, whether there is absence of the P wave, or if there is a present P wave, or if there is high amplitude of the R wave as well, okay? And if we're looking into the sinus tachycardia, okay, you have to look for the Again, the presence of the P wave, which is going to be evident here. Okay, you're not going to be seeing the P wave in the AFib. You're not going to be seeing the P wave in the PVC as well, and also the VTAC. All right, so that's what's going to make it different between the other options. Now, looking into the clinical features here, or the different changes, especially with the atrial fibrillation, what you're going to see instead is the irregularity in the rhythm. You will not see a uniform formation of those waves. There's no P wave, and the ventricle will be irregular as well. The ventricular response will be quite irregular. Okay. Now, again, we have our answer here as sinus tachycardia. It has the QRS, it has the P wave as well. Now, moving on to the next. While attending to a client who recently suffered a myocardial infarction, the nurse observes 8 premature ventricular contractions within 1 minute on the cardiac monitor. The client is currently receiving an IV infusion of 5% dextrose in water and oxygen of 2 liters per minute. What you should do first. What you should do at this point. Okay. While attending the client who recently had MI, the nurse observes 8 premature ventricular contractions within 1 minute on the cardiac monitor. The client is currently receiving IV infusion, D5 water, and oxygen of 2 liters per minute. What should the nurse do first? Is it A, administer prescribed analgesic? Or is it B, increase the oxygen concentration? Or is it C, promptly notify the medical provider? And D, increase the IV infusion rate? Okay, what you have here is 8 PVCs. Okay, in 1 minute. So you're answering letter C, promptly notify the medical provider. Okay, we'll reveal. Yeah, that is the correct answer. Why? When you are seeing 8 PVCs in a minute, or anything that exceeds 5 to 6 PVCs, that will cause you to call the medical provider. Make sure that you notify them right away, especially that our patient has suffered the MI recently. This can predispose them to developing the ventricular irritability, such as the VTAC or the VFib. Remember about the inflammation that follows after the necrosis, the infarction in the muscle tissue. It will cause the inflammation and eventually will lead into the irritability of the myocardium. And that is why it can lead into those life-threatening arrhythmias. Okay. Now, notification to the doctor is very important here, guys. All right. You have to let them know right away in order that we can intervene those life-threatening arrhythmias, make sure that we can administer the needed medication in order to stabilize the heart rhythm. If you answered letter, where's that? Medical provider is the correct answer, letter C. If you answered letter A, administer a prescribed analgesic. This is not indicated as a primary intervention for this patient with 8 PVCs. It's not really going to address the premature ventricular contractions. As we know, it's not one of those causes that we had identified earlier. Now, if you're going to select the increase oxygen concentration, will that help? Yes, it can help with the, what do you call this? With the patient's perfusion to the heart, it will help. It will at least maintain the perfusion, but it's not really going to manage. It's not a priority intervention to manage or to get rid of the irritable rhythm, okay? So we want to make sure that we are addressing first by letting the doctor know, because the oxygenation probably would happen as a secondary intervention. What about letter D? Increase the IV infusion rate. Will that help? No, it doesn't. It will not be able to address the premature ventricular contractions, because with the PVCs, especially with the 8 PVCs already, there is already that predisposition that the patient will convert into a VTAC and V-fibrillation, okay? So the infusion rate will not address that. Our patient does not have an issue with fluid volume. We don't see that in the scenario. We don't have that information that they need to be given IV fluids, or increase the IV fluids rather. Or let's say that the patient needs more O2. We don't really have an information that the patient has hypoxemia. Do you see it? I don't think so. I don't see an information about low saturation. We don't have that. Is there an information that the patient has pain currently? No, we don't have that. So there are no indications to administer analgesic. There are no indications to administer oxygen or more oxygen or increase the concentration of oxygen. There is no indication that the patient needs a higher flow rate of the IV. No, we don't. And so at this point, in order for us to prevent much more life-threatening complication, is to notify the doctor so they can give us medication orders to control the irritability of the ventricles, okay? So again, our focus here is to prioritize the patient's safety. Make sure that we are letting the medical provider know that there could be an impending complication to set in, such as those life-threatening arrhythmias. That's pretty much it, okay? Now let's move on to the next question here. It's almost 3 hours. Okay, question number 14. A nurse is educating a client who recently had a myocardial infarction and started taking clopidogrel or Plavix. The teaching plan should cover which of the following points? Select all that apply. Okay, the question states, a nurse is educating a client who recently had a myocardial infarction and started taking clopidogrel Plavix. The teaching plan should cover which of the following points? Select all that apply. Is it A, the client should promptly report unexpected bleeding or bleeding that persists? There's B, Plavix should be taken with meals to enhance its effectiveness. Or C, increased bruising and bleeding. Increased bruising and bleeding gums may occur as side effects. Letter D, Plavix prevents platelets from clumping together and forming clots. And letter E, it is advisable to drink water after taking Plavix to aid absorption. And guys, don't get fooled by the words here. Eliminate those distracting words, okay? Those descriptors that might cause you to answer or select the wrong answer. So be careful, guys. There's so many distractors in this selections. So we are talking about a patient that is taking, or will be started rather, on Plavix. And so you will be giving a teaching plan. So what would be the teaching plan? What should be included in that discharge teaching? Okay, we have answered ACD, 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 ACD. Very good, very good. So let's take a look into the letter A first. The client should promptly report unexpected bleeding or bleeding that persists. Yeah, well, that is correct. Well, what is this medication? Plavix is an antiplatelet medication. It prevents antiplatelet drug. And of course, I know that this is, it has that specific name, okay? And so this is what we call as the adenosine. The fancy name of Plavix is adenosine diphosphate. And I'm sure you're probably familiar with this one, diphosphate. And this is a medication that actually will prevent the aggregation of the platelets in order to inhibitor. It will prevent the binding to the ADP, okay, receptor in the platelet. So this medication is going to be helpful in preventing occurrences of blood clots, and this is mostly ordered for those patients that may have the thrombosis, especially in this MI patient. So we are going to teach them to report if they have any bleeding signs. Any signs. Ecchymosis, hematoma, bleeding from the IV site, rectal bleeding, black stools, gingival bleeding, nosebleeds. Those are the things that we're going to have to tell the patient. If they probably notice a discoloration in their urine from being yellow-orange to reddish, you have to tell them right away, hey, I just want to make sure that you understood my teaching. Can you please tell me what you understood about the side effects of the medication? So make sure let them enumerate what those possible side effects: bleeding in the urine, bleeding in the GI tract, bleeding in the upper GI, the gums, the nose, IV site, the skin, bumping into hard surfaces can easily cause them to have bruising, hematoma, ecchymosis, or let's say petechiae. Make sure that they will be able to recognize those manifestations. Those need to be reported by them. Okay. Now let's take a look into B. Plavix should be taken with meals to enhance its effectiveness. Do you think that the food will enhance the effectiveness? No, it doesn't. There is no such thing as adding the meals or food to allow more absorption to the Plavix. No, it doesn't. This is the caveat though, guys. When your patient is going to be taking the Plavix, it would also help them to have some food, at least a little bit, not for the reason that it will help their digestion, but will help protect the GI lining. Okay, you want to make sure that you are preventing the possibility of GI ulceration. So that's why we're going to give the medication with food, not because we are promoting absorption rather, not the absorption, but we want to prevent the ulceration in the GI mucosa, especially the stomach. Okay. But since this is telling us enhance effectiveness, this makes it wrong. Okay. But again, you can give this with food to prevent GI irritation. Now, letter C. Increased bruising and bleeding gums may occur as side effects. Yeah, I already mentioned that one. D. Plavix prevent platelets from clumping together and forming clots. Yeah, we have mentioned that. And E. It is advisable to drink water after taking Plavix to aid in the absorption. Yeah, we always recommend our patient to drink water, of course, to allow the medication to go down into the stomach, but it doesn't really aid in the absorption. This is what's making it wrong. Okay. All right. So your answers are A, C, D. Okay. Take a look into your answers. All right. So that is it for today, guys. And again, we are inviting you to enroll into our NCLEX program at www.stancoast-nclex-coaching.com. Make sure that you do that so you will be able to engage with us. We have all the freebies as well on top of the 3,000 NCLEX-style questions 10 hours of animated videos. You will be able to access this for 6 months once you subscribe. And we're also going to be supporting you with your questions. We're going to have interactive lectures as well. So make sure that you are signed up to our course. So that's it for today. I really thank you for your participation this morning. Tomorrow we will still be focusing on MI. We're only 3/4 of the MI topic. But again, there's still some more. We still need to go through the different diagnostics, preparation, more of the pharmacology in MI. What else? Yeah, I can't think on top of my head right now, but we are still in the 3/4 of the topic. And so we will engage some more in so much more difficult questions. Probably I will be bringing in some NGN, probably more SATA. But again, I thank you so much for your attendance. I really enjoyed this session, and I'll see you again tomorrow at 9 p.m. Guys, thank you. I'll see you again. Bye-bye.